Hi, my name is Matthew. I'm just going to be discussing a few things with you today. So I'm going to be discussing rapid sequence intubation and also capnography. So with the rapid sequence intubation, I'm going to break it down into two parts: pharmacological and planning, and also the skill side of things. So with the indications for RSI, you might have someone in acute or respiratory or cardiac arrest, respiratory distress, staticus epilepticus with decreased mental status and respiratory status, inability to protect their own airway, so it might be compromised by drugs or alcohol, possibly even trauma. They have inability to breathe effectively, or they have a potential for an obstruction or have an obstructed airway as a result of anaphylaxis or trauma such as burns. Now there are a few contraindications. So the absolute contraindication is reaction to medications. Now the relative contraindications for RSI, potential cervical spine injury, or also if you do an airway assessment and you predict they might have a very difficult airway to manage sort of thing. Now the complications associated with RSI is hypoxia, difficult intubation, desaturation, cardiac arrest. You can also cause damage to the teeth and inside the mouth, causing lacerations and bleeding. There's esophageal intubation and also esophageal trauma, also barotrauma as well, and also can cause aspiration and bradycardia. Now there are special considerations as children have superior and inferior larynxes and a floppy epiglottis as well, or larger aphobia. You may have to use a different blade with the kids. With adults, we use a Macintosh. With a pediatric, consider using a Mueller blade depending on their age. Now, we use a 9 Ps method when discussing RSI. So you've got the plan, preparation, the protection of the cervical spine, the pre-oxygenation, the positioning, pre-treatment, paralysis and induction. Also confirming placement of the tube and post-intubation management. So with the plan, it's just having open communication with everyone, discussing so everyone knows their roles, and if there's any complications, you know, can't ventilate, can't oxygenate scenario, we know our backup plan. So we have a quite quick diary, OB kit ready if we need to, with a scalpel and some preparation and a 6mm ETT tube there, if we need to do a front of neck airway. We then have our protective equipment, so glasses, mask, and also gloves here as well. Now we've got the preparation, so we've got all the drugs prepared. So we use dexamethasone at 1 to 2 milligrams per kilo, or the rocuronium, which is 0.9 to 1.6 milligrams per kilo. We have an induction agent of propofol or thiopentine, normally about 100 milligrams induction used for that as well. Now you also have your medications used for sedation as well. So you have your ketamine, which we use at 1 to 2 milligrams per kilo, or you have your midazolam, which is 0.1 to 0.2 milligrams per kilo. Now you may have use of a vasopressor as well during the procedure with a drop in blood pressure, which is at 10 to 30 mics as well. Normally 10 mics, and when they become unconscious, you might have to increase it to 30 mics per kilo. You also have the use of fentanyl as well as opioid sort of based medication, in which you can use to post-intubation sedation. Now fentanyl is about 1 to 2 mics per kilo. Alright. Now for documentation, so position, we've got the positioned in the ramping position already. We're not protecting the cervical spine at this stage, so we're not thinking of any potential injury. So we're going to have to pre-oxygenate the patient. We use a BVM attached to a mask for ventilation. Now you might have to upgrade the airway a little bit as well, so consider the use of your OPAs or your NPAs as well to oxygenate the patient. Now if the patient has sort of facial hair or has difficulty ventilating, you can consider using an LMA as well. And then make sure they have intravenous access as well, so we can start to introduce the drugs and medications. I'll start to move into the skills side in a second, but just for the key documentation points for that, just assess, like, document how many times you were attempted intubation, if there's any contingency plans, the amount of drugs given to the patient, what made it difficult, any positive or negative reactions, and if the cricothyroid or the Salix maneuver was performed. Now, safety considerations, again, PPE, prepared to, you might have to manually ventilate for a long period of time. You can't intubate, but you can provide ventilation through LMA or mask, full monitoring, and the ideal induction is a rapid onset and rapid recovery. Now it comes to the skill side of things. So given all our medications, we're pre-oxygenated patients, we've got them in a good position at the moment. So you'll normally have an assistant doing this. So there's a couple of different methods in which we can use to insert a tube. So we've got the stylet placed inside of a ET tube, which you can use to pass through and then pull the stylet out. You could use a bougie as well, just to feed that in first, and then feed the tube over the top, and then also you can just insert the tube itself. Now you just want to check to make sure that the cuff does inflate and deflate prior to insertion of the tube, to make sure there's no leaks or holes in that. So coming to this field, we're just going to insert the blade in here to the right, with the sweeping motion to the tongue to the left. And now you don't want to leave or pivot on the joint here, sort of thing. So once you get it through and into a position, I like to keep my thumb pointed that way towards the end of it. And then when we have a little bit of a head tilt, that's the way you want to travel with the blade, with the handle. So with your non-dominant hand, just sort of pull in that direction until you can expose the vocal cords, and then just feed the bougie down and pass it into the airway. Now I'm just going to pause the video there for a second, just while I secure the airway. Now I've got the airway, so what I did was I fed the tube over the bougie and then I inflated the tube with 10 mils of air. Now I secured it using the tie. Now I've got a bite block in there to protect the tube from being bitten down or occluded by the patient. I've got it connected to a filter and then connected to the BDM. I just confirm placement by using a stethoscope and also taking air. I can also confirm placement by using tube misting and also capnography as well. Now they do have a few different capnography devices. You have a chemical reaction one, which just changes colour when the patient breathes out. You have a little portable one which you can connect after the filter there, and it gives you a readout and a wavelength as well. Or the other one, you use a CO2 sampling line as well, which connects to a light pack or a monitor. Now with documentation for the tube, you want to document what size tube you used. Also, if you look at the side of the tube, it has markings there. And then you just want to mark either at the lips or at the teeth of what centimetres it was that the tube was placed in, and you visualise it passing the cords. The other thing is how many attempts were made and if there was any selectivity required for thyroid pressure or any complications that may have arisen from it. Now just to talk about CO2, so the indications for using CO2 may be cardiopulmonary resuscitation, or you have a return of spontaneous circulation. If you want to confirm the intubation, as we did just then, during procedures which require sedation, just monitor their ventilation, as they may be hypoventilating or hyperventilating. Now, also it's useful in monitoring patients with raised intracranial pressure, or also patients with pulmonary diseases as well, or pulmonary embolisms, or metabolic disorders or metabolic acidosis. Now, there's a few ways in which you could use it, sort of thing. So there's the mainstream, the side stream, face mask or nasal prongs as well. So it's just simple. Some depends on how you're going to use it. Some have a nasal prong to the CO2, which is got there. And again, like I said, a little portable device that connects there and it gives you a waveform. Now, there's a few considerations. So if you don't have a waveform, consider respiratory or cardiac arrest, esophageal intubation, tracheal tube becomes displaced or dislodged, breathing circuit becomes disconnected equipment failure, or the tube is obstructed. Now, samplers are generally single use, as consolidation can sort of build up and affect the readings and all that sort of stuff. Certain medications can also indicate, can also change the reading on your CO2, so such as your sodium bicarbonate and your adrenaline. Yeah, that's pretty much it for everything we had to discuss today. Thank you very much for listening.